tired of our time. Now we are looking from the background of David. And David is coming with the faith, coming with the confidence, coming with the hope that yes, God is behind him and he shall surmount any obstacle that comes our way. Well, a rider from that, this is not a physical fight. If it were a physical fight, it's going to be like a war. But it's not a physical fight. This is a fight that will need more of a mental thinking, attitudinal thinking. If it is so, we begin to ask ourselves, in wars, do they really use physical strength, or they have a combination of physical strength and intelligence? When you ask experts like John Keegan in the 40s, who had written so many books about war, in one of his books, he said intelligence in war. And he spoke at length about Napoleon Bonaparte, the great man, the great French warrior. And of course, if you remember in 1870 to 1871, there was a great war between France and Germany. And what happened in that? Germans defeated mercilessly and spectacularly too the French, led by no other person by the great general himself, Napoleon Bonaparte. Having said this, it now ended the hegemony of France. Now, a rider to that, the age of war with big armies is past. But we now live at the age of war with big intelligence. And that is why I put this slide. They fear those with knowledge and control those without it. Why are we having a lot of clashes? Why are we having a lot of difficulties having to make a progress? It is because they are aware that when you want to sit down to discuss what knowledge is all about, you will not be controlled. And like I'll keep on saying, nobody wouldn't want to have an inferior. At any moment, you would prefer to have somebody lower than you so that you can control the person, you can modulate the person, you can remote the person to which direction you want to. And that seems to be the scenario to which we find ourselves as pharmacists in West Africa today, particularly Nigeria. Each time I'm talking, I may be swinging between Nigeria and West Africa. Candidly speaking, on this audience today, you have some viewers from Ghana. I've seen Oscar Bruce. You have some viewers from Liberia. You have some viewers from Sierra Leone. You have some viewers from the Gambia. Beautiful. But the truth of the matter, Nigeria is blessed with a humongous number of population. We have up to 26,000 pharmacists in Nigeria. If we can get it right, by implication, others will really get it. But sometimes again, the number does not really matter, because Ghana has a recognized, a well-structured consultancy affiliations with their civil service scheme. Liberia is working towards that, but Sierra Leone has also gone ahead and did to have that organized structural scheme. Ditto for the Gambia. However, Nigeria, with our large population, once we get it right, I can assure you that the remaining persons or the remaining countries will equally get it right. On the slide I'm sharing, somebody asked, what is the meaning of life? And the response from the other side is, I don't know, the computers are down. That seems to be our quagmire in our society today. Most times because of our lack of reading, because of our lack of knowledge, because of our lack of involvement in contemporary issues. If a question is raised, we now quickly go to our computers, we quickly go to our handsets, we quickly go to modes of information seeking, even in the presence, embarrassingly, in the presence of the patient. That goes to say, we may not necessarily, we are actually looking for the respect. Respect is earned. So we should be able to work towards seeking for knowledge so that nobody can control us. Having said this, from the topic I was given, there are 3 key words in it: expectations, consultant, and clinical settings. I boldened the consultant because that is the key. That is where we are going to end in our discussion. But expectations could be high, could be low, because expectations are driven by your personal motivation. Expectations are target that you intend to have a desire to achieve a particular target. If it is so, you should have a goal, you should have a vision, you should have a mission. What is our goal? What are our missions, or what is our mission? And then what is our vision to achieve what we have put for ourselves? The key word, like I said at the beginning, is a consultant. Now, let me take 2 minutes to give us a background information on consultant. It is so unfortunate that there are some parochial, narrow-minded thinkers that are thinking that consultancy is sacrosanct to a particular profession. Let me give you the history of consultancy so that you can see where knowledge is power. People, a lot of us do not know that the word consultancy was actually coined by a chemist. He was working with Massachusetts Institute of Technology in Boston. His name is Otto Little, popularly known as Otto D. Little. He is in the Faculty of the Management Sciences, and this thing happened in 1886, 1st October. He was that person that discovered the acetate. He's a chemist. He worked tremendously. In between his work and research and discoveries, he decided to show expertise in his field. And then he coined out the word consultancy, management consultant. That was the beginning of the term consultant. So it amazes me when we are rewriting history because of lack of knowledge, to say the term consultancy should be sacrosanct only to a particular sect of practice. Particularly in this our case now, in healthcare delivery, it is actually a spectacular failure to believe that only one profession should have the sanctity of having consultancy. Consultancy, simply put, is expertise, the display of expertise in whatever one does. And in this case, as pharmacist, your expertise is on drugs. We are talking about experts in drugs. I'll be quick to say that what is going on now is a very simple ego battle. Ego battle between pharmacists, between physicians, most especially because they know the intellectual stamina of the pharmacist vis-a-vis their own training at the university. But more often than not, I blame them little because we pharmacists have actually not lived across board. I am sorry, I may not tell you what will make you happy today. I may depress you in more instances, probably impress you in a very few instances. But let us all open our minds, open our hearts to this discussion. I believe that the purpose of this weekly lecture, weekly interaction is for us to improve regardless of whose ox is God. I'm a lecturer with the University of Jos. I teach pharmacy students, I teach medical students, I teach nursing students. While I teach, I can see a distinction in intellectual stamina in pharmacy students while at the university. We are so brain boxed, we are so tied with a lot of curriculum that has kept us away from socialization. And once we leave the university system, we tend to celebrate the freedom because of the difficult, amorphous torture that we passed through for 5 years. So we over-celebrate it and we forget our books. In between this period, the medics are coming from the abyss of the academia and intelligentsia. They are cleaning, they are dusting their papers, their apprenticeship, and they are moving the ladder gradually. By the time they are 2 years, 3 years post-graduation, as they ascend on the ladder of knowledge, the pharmacists are descending on the ladder of knowledge. And that explains why more often than not, they tend to be looking at us as challengers in some instances, adversaries in some instances, but they know that if they drag, they may eventually conquer because our knowledge gap is a little wide when we make a comparison to theirs. Well, the winning bullet in my discussion with you today is going to be on knowledge. It's going to be on application of the knowledge, because knowledge without applicability is a waste of knowledge. And that seems to be the bulk of the situation pharmacists have found themselves in West Africa, in Nigeria in particular. Because the society can only take us to be relevant based on what they see. And if I will ask again, what do you, as CPAN members in Nigeria and clinical pharmacists in the remaining part of West Africa, what do you have on the table? What are you putting on the table for people to see? I hope I'm clear enough, moderator.
Exactly, sir. You are clear, sir.
Am I lost?
Yeah, you can go ahead, sir. You can go ahead, sir.
Maybe no problem network, because no, okay.
A little bit network crack. You can go ahead,
okay. Sir. Okay. So now let's look at it. We have a basic ingredient. That ingredient is that we are all pharmacists. Now let's have a general overview of whom we are. Then what do we aspire to become? Like what Bob Marley will say in his popular music, Exodus. Bob Marley said that we know where we are going. We know where we are from. We are leaving Babylon and we are going to our father's land. That's a very popular music by Bob Marley, Exodus. Now we as pharmacists, we know where we are coming from and we know where we are going to. So far, we practice as generalist pharmacists. The most elementary roles that we do, which we are expected to perform in the hospital, whether you are a pharmacist, whether you're a clinical pharmacist, whether you're a consultant pharmacist, is majorly, especially in the hospital, is optimizing patient care outcomes, reducing the burden of drug therapy problems. Majorly, that's what we do. But if I'll ask ourselves here, do we really do this? Basic things, the rudiments, the elementary rules of a pharmacist. Do we perform these duties in our hospitals? What are the characteristics of a pharmacist? What are the values of a pharmacist? What are the abilities and capabilities of a pharmacist? Who really are we? By the time we answer the generalist term of a pharmacist, we now narrow down to the next bigger one, a consultant pharmacist. Because having gone through my interaction with one or two individuals on what they do as pharmacists in their various places, more often than not, we are seeing like people that receive instructions, people that just do dispensing activity in hospitals. And that is where our fundamental problem is. And that's why I'm very happy with the emergence of CPAN, the Clinical Pharmacy Association of Nigeria, which is trying to make a redefinition of pharmacy practice, especially in hospitals. And now with the approval of the consultancy cadre, and also the subsequent input of West African Postgraduate College on our students, we are beginning to see the light. Now let me give you some information. Let's go to statistics. Facts don't lie. Let us be guided with some statistics. Then we may understand what we're talking about. All the hospitals, all the sicknesses, all the health conditions. Are you aware that 80% of health conditions are treated with drugs and pharmaceutical products? Except the 20% possibly could come from spiritual medicine, whereby you pray and make incantations, and then you heal the person probably. But 80% of conditions in the hospitals in health require drugs and pharmaceutical products. Then where did we get it wrong? Where did we get it wrong? It implies again that we're supposed to control it 80%. We're supposed to control the health system 80%, but we missed it somewhere. Probably from the initial orientation of pharmacy as a profession. So we are on the quiet side. We are not looking at ourselves as leaders in what we do. We are hiding on another person's shadow. And that explains why we are having a dominance factor in our practice today. Are you also aware that 50% of patients with chronic illnesses are non-adherent? This is a very terrible situation. Diabetes, hypertension, psychiatry, cancer, a lot of diseases, some infectious diseases. All these are chronic illnesses that require daily management. But we have 50% of patients that are non-adherent. It's a very serious situation. If it is so, are we aware that there are lapses in our duty? I have always told someone, you get scared that somebody will usurp your position if you are not doing your job properly. And that explains where we are having one or two skirmishes in the health system. Then let's look at this bigger one. Are you aware also that 80% of treatment failure is as a result of pharmacokinetics and its variables? Narrow this 80% down, you will see that 55% of the 80% is as a result of pharmacokinetics. Then 30% is as a result of fake and substandard drugs. Give me the statistics so that you can see that healthcare itself rests on the fulcrum of pharmacists and pharmacy. But we are not looking at it from those perspectives. We are missing it. We are not looking at it from those areas. We have left it and we are struggling in areas that do not concern us into. If it is true that these statistics I am telling you, I'm showing you on this slide, if it is true, then where did we get it wrong that we are not in control? Have we taken time to look at the domain of drug interactions? Have we taken time to look at the domain of prescription errors? Have we taken time to look at our level of interaction with other professionals? Because it is when you interact with them that they will know the stuff you are made of, that they will know what you have. But I must comment at this period too. Most times we don't want to have this interaction with them because of an inner complex or a low self-esteem which is affecting our performance and is affecting our activity. Now the big problem. Like I told you, we focus more on our problems and we spend little time or no effort completely in searching for the solutions. My Ghana colleagues are here. Kwame Nkrumah, a very popular African, once said, enough of the lamentations, let us start organization. If it is so, I am happy with this topic today. I'm happy with the choice of what do we do next? What are the expectations of a clinical pharmacist so that we get where the problem is? But you should take home this information. Problems abound everywhere. When you sit and say, pharmacy is the only one that has a problem, you have missed it. And that is where my younger colleagues plentifully make errors. They will keep on blaming the senior colleagues. You blame the senior colleagues. You don't know that 1 year post-graduation, you are somebody's senior. 1 month post-graduation that you started, you are somebody's senior. So that person that is 1 month younger than you is also looking at you as part of the people frustrating him. If we continue to be making this frustration in our line of thinking, we will never get it right. The blame is on you. The blame is on me. The blame is on all of us. All of us have a portion to share in this blame. When you look at the screen that I'm sharing today, you can see an elephant. Walking beside it is a lioness, and then a cub, the baby lion. And the story is that the lioness had a baby and the sun was too scorching hot. And what happened was the elephant knew that the baby cub will die. So the elephant carried the baby cub on its nose. That is what the lion lacks. And they trek across together as friends. Once they get to where there is little temperature drop or where there is water, the elephant will neatly relinquish or submit the cub to the lion. And that is how work's supposed to be. That's how we're supposed to work as a team. We're supposed to collaborate. We're supposed to facilitate. We're supposed to help. We're supposed to motivate. We're we're supposed to encourage, we're supposed to influence, we're supposed to move along as professionals in the area that we find ourselves. Now, CPAN is an association of clinical pharmacists. You have your own requirements. You have your own prerequisites that you have to attain before you get the membership of the CPAN. Let me take you back again to the history of how pharmacy started. I'm sorry, I'm going history, juggling around, but that's how I think, that's how I teach. I'll mop the histories, the stories at the end of the day to put them in one pot. Pharmacy started as a certificate course in Nigeria, 6 months. In the 1887, I think, the first pharmacist had a training of about 6 months. Eventually, it became a 2-year course, a diploma. Eventually, it became a BSc. Eventually, it became a B.Pharm. Now, it is a PharmD. Now, to the bigger problem, PharmD and WAPCP certificate, the fellowship. If it is so, then we must have a change of thinking. They were changing from the OND to the BSc, to the B.Pharm, to the PharmD. That does not diminish the status of the OND holder if he is alive today from being a pharmacist. He's a pharmacist. The same, no profession starts from what it is today. You move gradually from somewhere to somewhere. You continue to change based on the evolving landscape. So pharmacy is not an exemption. We have changed from several nomenclature, and happily today we are at the B.Pharm category, and happily West African Postgraduate College also offers the fellowship of the Postgraduate College, FPC Pharm, which a lot of you in CPAN, a lot of you listening to me today, are either holders of it or aspiring to have it. If you don't, I will advise you to do that, because that's the only channel that we can get to the consultancy cadre. If it is so, then there must be a change in our orientation, because if we will behave the way we are, I can assure you, the profession will die with the disposition of contempt. I can see danger. I can see danger between PharmD and FPC Pharm. FPC Pharm is a recognized consultancy cadre. PharmD is a clinical first degree. Post-graduation, you spend 3 years after graduation, you enroll for 5 years into the WAPCP training, which is a total of 8 years, and it now qualifies you to be a fellow and by implication to be a consultant. We have to be guided by the rules. We have to be guided by the laws. That is what the law permits. For you to be a consultant, you must have a fellowship of the West African Postgraduate College or the National College, as the case may be, which I want to tell you that Nigeria is aspiring assiduously to have its own national college one of these days. The law first, what does the law say? If the law says PharmD is a first degree, FPC Pharm is a consultancy, so we shall be. We should be guided by the law. Lawyers will wear white and black when they are in school, and they wear white and black post-graduation in courts. That's what the law says. Lawyers, you can have an LLB. When you look at the requirements, I mean, my qualification, you know that I have an LLB, but that does not make me a barrister and a solicitor because I have not gone to law school. Because you must go to law school before you practice as a barrister and solicitor. That is what it is. No matter how intelligent you are as a lawyer, if you did not go to get a bachelor's degree in law from a law school, you cannot practice. I have a friend. When we finished university, he made a first class in English. And that's about 29 years ago. He made first class in English. Do you know that after we graduated from the university, after NYC, he refused to do any work. He felt he was too big to do his own work, arrogant about his first class. He said he will only work with CNN or BBC or a big multinational media house. He didn't want to start from radio, television, from any local for him, because his first class, he felt, would take him to high heavens. 1 year passed, 2 years passed, 5 years, 10 years. He came to me after about 15 years and asked me one time, I should give him some money because he needed to do something. And I told him, why can't you just come down from a hybrid tower and start something small? Develop from it. Now, all our mates are commissioners, some of them are ministers. You are still working the streets begging for money. Now, any job that comes your way, they will ask you for experience, what you like. And I asked him, if you are looking for what your mates are as you did 29 years ago, your first class mates are CNN and BBC. Now your mates are ministers. Go and write an application to the president of the country, application to be a minister. You will see that nobody will consider you because you did not act as a proper leader is supposed to. I give you this narration so that you can see whatever it is, we have to follow the protocol, we have to follow the law. Let us not behave as if we are not laws. And what Fidel Castro will say, in the state of lawlessness, law abiding is illegal. We are not in the state of lawlessness. Pharmacy is guided by law. The way I have interacted with people with FAMD, they seem to be making FAMD to look as if FAMD is a statement that our undergraduate training was inadequate just with a big farm. It shouldn't be. That's why I brought the elephant, the lion, and the cub. You have to carry everybody along, whether you are a big farm holder, whether you are a family holder, whether you are a PhD holder, as far as the evolution of clinical pharmacy. Those that are in clinical pharmacy, let us unite, organize ourselves, and move together, search for knowledge, seek for knowledge as it is. Okay, now coming back to our topic, who is a consultant? In Nigeria, we have a lot of challenges, name dropping. The rest of the world, they see things in a different prism than what we see in Nigeria. But who is a consultant? Simply put, a consultant is an expert. He's an expert in the delivery of his expertise in clinical care. We are discussing about hospital setup. A consultant should be able to recognize and manage complicated or complex cases in patients. A consultant should have a very good and sound managerial decision. A consultant should be able to imbibe qualities and virtues of teaching so that you should be able to teach the younger ones. A consultant should be able to participate actively, robustly, and genuinely in research. This research can be from the public sector, can be from the private sector. A consultant should be able to look inwards at local devices to improve on local devices for the benefit of the institution, for the benefit of the patient. If it is so, as a consultant, we have to draw our goals. Like I said, we draw our missions. Like I said, we draw our vision so that we can all aspire to be the same. The most important aspect of consultancy, my brothers and sisters, is behavior. We should be able to change our mind, change our thinking. Like I have said on this slide, when your mind is prepared, a prepared man is a prepared mind. And a prepared mind is the beginning of success. So first of all, we have to fine-tune our thinking and believe that yes, we are consultants, we are experts. Once our mind is already tuned to that tuning load is the beginning of success. Now, as a consultant pharmacist, you should be able to live with high esteem. Unfortunately, a lot of us have very low esteem of ourselves, and I can tell you, self-esteem is a major ingredient in leadership, a major ingredient in confidence building. When you have low self-esteem, it tends to give you poor human relationship with others. You have trouble with relationships, and it makes you less productive. But when you have a high self-esteem, it gives you ability to cope with challenges, and it gives you self-confidence, which is openly expected and unique to. Self-confidence is another ingredient that you need as a consultant pharmacist. You should work with confidence. talk with confidence. And all this confidence and self-esteem, they move hand in hand, and they don't separate, or they are not the same twins, rather, with knowledge. When somebody is very knowledgeable, you see working confident, and he has a high self-esteem. And these are the basic needs of a consultant. The consultant should be able to participate in research. Research here now, like I said, we applied research, we do professional research. How many of us in CPAN would have CPAN is a competition of intelligent young men? And how many of us have taken time to do one simple research in our setup, whether in the private or in the public sector? If we can do that, now gives us a pointer that you are aiming expected. I mean, it is expected that this is a consultant. So you must be able to put your hand into research. There are so many examples of that pharmacists neglect. Those in community pharmacy, I keep on giving this example. You can sit in the comfort of your office and do an assessment of prescriptions that flow in. You can sit in the comfort of your office and monitor the number of antibiotics that flow in from January 1 to January 10. If it is so, you can monitor the period in a year. You can know that antibiotics sell most in March or April. Then as a researcher, you can use reasons for it. That will help policy making. You can now suggest in a policy based on the research that you find yourself. But when pharmacists, we say we are consultants, but our knowledge of that will sleep. It gives a wide gap, a pitfall that we are going to bury ourselves if we are not careful. A consultant pharmacist, you are expected to be a trainer. You should open your hand to the younger ones and put them into training, rigorous training, total training, which you yourself must be knowledgeable. I keep on saying one thing. Mentorship is missing completely in our curriculum and in our practice. We should be able to be mentors to the younger ones. Mentorship, training, research, conscious development of self-esteem and self-confidence. These are the expectations of a field pharmacist. These are the expectations of a consultant pharmacist. These are the things that we need. Most importantly, how do you control your emotions? How do you control your anger? I hope all of you have taken time to know yourself. Like what Socrates would say, know thyself. Have you taken time to know yourself? Have you taken time to know your temperament? Have you taken time to know how you can behave? For instance, this consultancy that the enemy is sheepishly making walking all around the clock, clandestinely around the clock to squash with the pharmacist. Emotional intelligence is what we need now. Not by shouting. The enemy is free. In a democratic environment, you are free to express whatever you want to say. The beauty of democracy is fools and the wise are mixed together in one place. You too, as a pharmacist, what is your emotional intelligence? Don't allow the anger deliberately being provoked by someone to spoil you, to have an emotional hijack so that you now behave otherwise and do the wrong thing. We need that. When you look at all I've told you, it is expected that as a consultant pharmacist, you should have a high self-esteem, you should have absolute self-confidence, you should participate robustly in research, you should get yourself consciously involved in training the younger ones. And remember, training the younger ones implies that you too must self-develop. You too must go for self-development conferences, workshops, seminars, courses, and schools, and increase your knowledge because you are passing knowledge from old generation to a younger generation, which means it is like a relay. You should participate in mentorship and most importantly, train yourselves as a team on emotional intelligence. All this boils down to one thing, is making you to be a leader. Because all that is a leader. And next time we talk about leader, who is a leader? Simply put, leadership is influence. That's the simple thing I'll tell you today. If you have nothing to take after all this lecture, whether it is 1 minute or 1 hour, according to what Dr. Solomon has instructed me, take the slide with you. Slide number 10 says leadership is influence. And influence, INFLUENCE, is an acronym according to Weber. I here, the influence in I means integrity. You should be a leader with integrity, so that when you talk, when you talk, people believe in you. You should be able to nurture. The N stands for nurture. You should be able to have confidence in people. You should be able to give them that opportunity to delegate duties and they to do it. You should be able to encourage them. You should be able to motivate them. You should be able to carry them along with you. You should be able to know them. A good leader should have faith in his people. And that is why a good leader should be able to give delegation. You delegate and then you supervise. So you look at the younger ones that are with you. A good leader should listen. Consultants should be able to listen to the younger ones. These younger ones, some of them have a lot of problems, and these problems are not major. All they want is for you to give them a listening ears. I have seen instances where senior colleagues would be frowning in the office. If the younger ones greet them, they will greet them as if carrying their burden on the wall on their head. Be free. Laugh with these people, encourage them, listen to them. The solution some of them will need is just your listening ears. A good leader should be a good listener. The you is understanding. You should be able to understand what the younger ones are passing through. You know that sometimes I have seen instances whereby students are not performing well because maybe they have some domestic problems, they have family problems, parental problems. When you listen and listen to them, you understand their mood and their dynamics, and you can give them good direction. A good leader should be exemplary. You should lead by example. A good leader should be able to navigate. If there is a problem somewhere, and then younger ones will come and meet you, you should use experience and wisdom, and then sort for options and alternatives. You should navigate out the trouble with the younger ones. It encourages them and it gets with you. A good leader should be able to influence by virtue of that to be a good communicator. I mean, this stands for you communicate. Communication is a two-way thing. Communication, remember, from what you learned in your undergraduate days and independent PCP, you are a student of the college. Communication is both verbal and non-verbal. It will interest you to know that verbal communication is just about 35%, while non-verbal is of 55%. And that is why we frown at dressing. Dressing is a non-verbal of communication. When you are not properly dressed as a consultant, somebody will see from a distance and mistake you to be a patient relation. Or the worst case scenario will ask you, please, who is the pharmacist? That is embarrassing. When you are neatly dressed, professionally dressed, the confidence is there. You yourself walking on the street, people will wait for you. A big man is coming, an important person is coming. That is communication. If you have not talked, if you are dressing alone, has spoken for you. And that's why we constantly talk about dressing. Those of you at the college, you know much about how I discuss about mode of dressing. Those of you at the college, you know consistently talks about dressing. And in fact, he had even sent some people out of examination on that WCP because their dressings were a disappointment by far below the expectations of a pharmacist. Leaders should be able to have empathy. You should be able to imagine yourself in the shoes of your colleagues. Please, these younger ones have a lot of difficulties. Listen to them. Imagine yourself in their own shoes and show some sympathy to them. If you can be able to show integrity, you have faith in your colleagues. If you listen to the problems of your ones, you have an understanding with them, and you live an exemplary life based on your integrity, and you are able to provide solutions by navigating, and you constantly engage them in communication, either verbal or non-verbal, and you show them that you empathize or sympathize with them in situations. I can assure you, you are influencing all of them. A consultant should be an influencer. Consultant should be a leader. Consultant should have self-esteem, should have self-confidence. The consultant should engage in research and training. The consultant should be able to be a mentor. The consultant should be able to maintain his calm, to display a high level of emotional intelligence, and the consultant should show those leadership qualities which I have just shown to you. Okay, now I'm going to say the bigger qualities of who the consultant should be. Let us look at it now. What are the roles of a consultant? A consultant should be able to demonstrate competence and experience. Experience does not just come like that. Experience comes with participation. Most of you in the hospital, please constantly get engaged and participate. You should be inquisitive on what is happening in your hospital. It will know that my first interest, when I worked at Lagos University Hospital for 1 year, that was for my internship. And during my internship, I developed friendship with almost all the physicians on campus. It got to a stage that some of them don't know whether I am a physician or I am a pharmacist or a dentist, because I related freely with them. How did I get that? Because I was going into the world, so what they were doing. A case in hand now will remind you, maybe friends. There was this lady, Elizabeth, they call her Baby Elizabeth. Exactly time the physician, the consultant made a recommendation of spironolactone 200 mg. And I was coming from the university, then and I said no, it was furosemide. I said no, you can't give furosemide 400 mg because I came with my G and G with my Lawrence and Barnett running in my head. And now I said no, it can't work. But something told me, when I go to the world and see, and I picked my lab boy down when it was. When I saw the student, I started teaching in confidence. I think it down to who he was. I think he was a consultant as I am. Eventually became the CMD of the hospital. So today is my very good friend. I bounced in and we spoke. I told him that no, you can't give that. He told me that no. And he said, young man, come. I followed him. Of course, I was in my 21, 22. I followed him. And then he started explaining what the book said. And I was stuck with absolute confidence. So he took that desire to make your courage. And he now narrated to me the reasons for my story. Into that I showed me that you can go a maximum, even 200 to 400. From that day, that man constantly made reference to me. I was an intern, for God's sake. Coming from the University of Jos, that was where I did my first degree. And then I was in Lagos. You can imagine the distance. Those of you that know Nigeria, as at that time, anything upwards of the North River, Niger, Benue, Apo, we were looked down upon. Then I suddenly found myself in Lagos, myself of lions and lionesses. And then I was coming from an unknown University of Jos, but I stood my head high. I stood my shoulder because I knew what I had in my head and I knew where I was coming from. I knew my background at the university. I was absolutely a confident person. And then that man became my friend. Till I left internship. Each time he's going on, I called me. We became friends, eventually became the CMO of the hospital. I'm giving this narration so that I can see confidence can make you learn. Experience, applicability of experience. As a consultant pharmacist, you must have that experience. You can't borrow experience. You can bring experience. It's what you do. So when you keep on going into what that experience I had with that consultant has increased my confidence status very highly. Why? Because I attended. A lot of you are withdrawing. A lot of you out of timidity refuse to blow out of the shell to go and get that experience in the world. You need to demonstrate confidence. Competence in your area of field, you are pharmacists, you are experts, you are custodians of drugs. You should talk confidently about side effects of a drug interaction, drug interaction, drug food interaction. You should talk about treatment outcomes and their therapeutic failures. You should, and also burden of treatment, and even the economy of drugs. These are your areas of competence. You should be able to train the younger ones. That's your role as a consultant pharmacist. Like I told you earlier, mentorship is like a relay. Unlike a sprint, that's like one person runs and wins 100 meters. In mentorship, you pass the baton to someone, passes to the second, passes to the third, generation after generation. Then there will come a time in 40 years when they mention your name. I am A19. Somebody said, are you the son to 19? That's 40 years from now, when they taught that to 19. That man taught me. That man did this. That man did that. Two things will happen. If you did very well, the younger person who is an older person, remember, the master was once a people. The person you treated, now, if you did bad, he's going to pass this bad to men to your children. If you did good, he's going to pass this good to men to your children. So that is the issue about mentorship. Mentorship is like a good driver and a bad car, or a bad car and a good driver. Whichever way we look at it, but we are talking in the positive aspect, whereby we have mentorship that we need to put hard of maybe, but the baby, throw it into the and keep the baby. That's mentorship I'm talking about. So let us start as consultants to be mentors to the younger ones. As a consultant, how cardinal in our duty from the pharmacist on that we swore, we are to provide care to our patients, regardless of race, regardless of religion, regardless of tribe, regardless of sex, gender. So we should provide pharmaceutical care for our patients. We should be able to make pharmaceutical care plans. And we should be able to collaborate with other professionals. And most importantly, if you're a consultant or team of pharmacists, it implies that you should be able to take responsibilities. I can tell you not once, not twice. When pharmacists go on what rounds, or when pharmacists find themselves and a junior company needs an offense, we quickly run away from the offense. Nobody wants to show stage. In your various places, you should be able to design a structure of pharmacists and then create a team, maybe 4, 5. One person should be there. That person should be the consultant. If a younger one does any error, it is not the error of the younger one. Please take that. You are accountable for it. You are responsible for the error of the younger one. You should take absolute responsibility. That's what the medics are doing. When a junior colleague does anything faulty, when consultants them, they all rally around and accept liability. That is the responsibility. You are now like a father. That is the area that we completely lack in our pharmacy training. As an expert in drugs, you are to be giving drug information services to the nurses, to the doctors, to the physicians, to the consultants, to the laboratory experts, to the dentists, to the physiotherapists, to all the health circles, and even to the patients, because you are the owner of the drug. In my language, we call hospital meaning house of drugs. That means it is meant to be my house as a pharmacist. But now they have neglected us, doctors in a small cubicle with a very tiny window in their kind to you, where you be teaching out their drugs. It shouldn't be. You are ordinarily to lead to have a problem. Oh, Anthony, you are raising your hand. Moderator, someone is raising his hand. Do I continue?
Hello. Who is the problem, Prof, is the network issue. It's cracking. I've actually sent information to Dr. Ibrahim Bello to know what they can do. People are complaining so much, but you can still go ahead. I'm talking about the network. It is not cohesive. They are not getting it. They are not really following. So that's what they are complaining. A lot of things. They say, moderator is not doing well, as if to say I'm the one doing it. Invariably, I'm not the one doing it. But I am actually appealing to Dr. Ibrahim to know whether he can do something to make it clearer.
It's not from me, it's from the prof. So we have to manage it. The network issue is from the prof. Yeah.
Okay. I have actually even sent mails to Prof to know that he can fine tune it to make it more audible and more clearer. So it is not coming from my side.
It was clear from the beginning, but towards the end,
exactly.
Yeah, so we have to continue that way. So there's nothing you can do.
It's not clear.
It's not clear. It's not clear.
Let me see if I can change position when I will help us with the network.
Okay, Prof.
I don't know whether it will help us with the network.
The network is really bad.
Is it clear now?
It's still the same thing.
Oh, yeah. Oh, yeah. Okay. Oh, there's nothing I can do again.
Sir, can you continue, sir?
Yeah, continue.
Okay, let me continue. Unfortunately, my slides are always very, very brief. I do more talking than putting it on slide. That's what PowerPoints are meant to be anyway. Okay, Madam, you are raising your hand. Any issue?
Don't worry, sir. Just continue, sir. That will be after the end of your presentation, sir.
Okay, let's continue. Probably we'll answer at the end of the discussion.
Yes, sir.
Well, let me try and be slower.
Yes.
Okay. So, as health experts, we should be able to give drug information services to the patients. We should be able to give drug information services to the healthcare professionals, and we should be able to, that on its own is going to improve on our relevance in the society. If that is done, and you realize that all these things I'm telling you, to collaborate with health experts, to take responsibility of actions, to be in charge of drug information services, to give pharmaceutical care plans, to be a mentor, to train and educate the younger ones, demonstrate competence. One thing is needed, and that thing is knowledge. We can't run away from it, you must have knowledge. It's the one cardinal factor that we need. The slide you are seeing, knowledge is asked. Always seek knowledge. Knowledge is power. And these are the things that will lead you to get sustained. Unfortunately, this is the area that pharmacists are worst. Pharmacists don't seek for knowledge. The truth is this. The truth is this. You can choose an area of interest as a pharmacist. You can choose one area of interest and develop yourself on it. For instance, if you are interested in endocrine pharmacy and a patient walks to you that he has diabetes, you should tell him, you can't have it, that's the patient, sorry. You are discussing with a physician now. A physician would place a patient maybe on sulfonylurea, maybe glimepiride, and then the person is not recovering. You, as the pharmacist, you have found out that there are better options of sulfonylureas, especially, example, the glimepiride. You can suggest, can we use the glitterides? Why? Because these drugs are good in chronic kidney disease. They are safe because they are excreted through the liver. It undergoes the hepatic clearance. That can be your advice to the physician. Don't just keep quiet and say, because the doctor says he wants glimepiride and I will not recommend to you. Why can't you try methaglenite? Methaglenite is an example of glitterides, and these drugs are good because they can be given in patients with chronic kidney diseases. And this patient that you are treating can see he has kidney disease. If it is so, doctor, I would advise you change this drug. You may have a problem like gaining weight, but these are more issues. They are not issues that will temper with the therapy. The therapy is better with this drug. However, you are going to have a decrease in postprandial glucose. When you talk to the doctor like that, the doctor will say, wow, this man really knows his word. Because you have chosen that area to understand it in and out. You can choose to be a toxicologist in your toxicology, or maybe in emergency crisis. Somebody walks into a doctor and then the person has swallowed an unknown substance, he collapses, lost Jesus, unconscious, bleeding and all that. You as an expert, you should be able to look at the patient, look at the associated symptoms, and then make a suggestion. As a pharmacist, I think since this patient is coming with diarrhea, there's an increase in urination, there's bronchospasm, there's heresis, I can also see salivation, I can see increase in lacrimation. Doctor, I think this poison is cholinergic in action, because cholinergic agents increase urination, they bring meiosis, they bring blah, 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 blah. If it is so, why can't we use a blocker of the cholinergic transmission? That doctor will expect you. Or if you decide that you are going to go into pharmacokinetics, beautiful. A patient is taking maybe phenytoin, and the patient walks to the doctor and then he is complaining. The doctor is at loss. He will now come in as a pharmacist and say, okay, doc, what is the problem? Phenytoin, you know that the absorption of phenytoin depends on the pharmaceutical company and formulation. Let me see the one that you have. You look at it and read. I haven't seen it. Oh, but doctor, are you aware that phenytoin has a high plasma protein binding? Are you aware that the saturation kinetics of phenytoin and its metabolite is an advantage of clinical importance? Doctor, are you aware that if the patient is on carbamazepine is an auto-inducer, it shortens its own half-life and half-life of other drugs too? That doctor will expect you. We know that yes, you have a sound idea of pharmacokinetics. Or if you want to wait pharmacogenomics, you can give examples on and tell the doctor, are you aware? There are people accelerators, some are fast accelerators. Are you aware there's an enzyme variability so that sometimes the cyclopilin for 50 enzyme can induce or inhibit? For instance, doctor, this P450 enzyme, the isomer 2S1 is increased in cancer patients. Is it possible that the drug that we're using has ABC activity on this isoenzyme, and that is why this patient is having a prolonged case of his cancer? Is it possible that we change? Because I can assure you that P4502 is important. It plays an important role in the synthesis and metabolism of lipids, including prostaglandins. When you talk like that, what message are you passing to the doctor? You are giving him superior knowledge. And that can only be gotten if you yourself have gone into reading, if you yourself have gone into, display of your competence. And that is the way we work. Believe me, if you do that, the doctors must, mark my word, must. They have no choice. They must respect it. This is what we are known for, unfortunately, in our hospitals. Take drug 3 times a day, we pass it, so be very unfortunate. Very, very unfortunate. Well, to cut a long story short, we should divert from this giving. Like what, do you know that even in the hospital, the pharmacy technicians respect us, not because they have to respect us, but they respect us out of fear. Like what other Camus would say, nothing is so indispensable than respect out of fear. I hate it when you respect me out of fear. And that's the situation for ourselves. We shouldn't be just dispensers. In fact, 80% of doctors look at us as their dispensers. I was in Port Harcourt some times back, and I was discussing with the CMD of the hospital, and he told me that the real estate government is more comfortable employing pharmacy technicians than pharmacists. I asked him why. He said because they believe that pharmacy technicians do the same role with pharmacists. And some pharmacists were there. And when I spoke to the CMD now said, oh, honestly, what you told me is very correct. I wish your colleagues will have a thinking the way you are doing. The man trained outside the country. And he said he has worked outside Nigeria. He has seen the robust intelligence of pharmacists outside. But coming in, he doesn't feel their impact. My niece is also a physician, and she tells me that. She tells me that, Uncle, this your WPCP, the way you are so passionate about it, I wish some other pharmacists are like that too. That is what all of us should be able to imbibe. Passion for change, passion for advancement, passion for creativity, passion for innovation. My colleagues, we need to improve on our self-development. Our self-development so far is very low. I must say that. I'm sorry to say that. We should choose an area of specialty, whether you want to go into pain, neuro, mental illness, oncology, hematology, endocrine, toxicology, critical care, emergency, metabolic, nutrition. Pick a field, and then develop your interest on it. For now, the confusion will be that what happens if you work in this place for 1 month, please transfer, you transfer. No problem. Rome was not built in 1 day. Let us create that specialty first. By the time you start showing your relevance in a particular field, nobody will transfer you. It is a process. You may not be there to win the prize. Martin Luther was there to celebrate the liberation of the black, but his name is a legacy in American history, in world history today, because of the role he played in emancipating the black race. You should be able to collaborate. You should be able to collaborate. You should be able to play in work. All these things cannot be possible if you do not ignore it. The truth is we must be able to up our game. Up our game. Like Charles Darwin would say, it is not the strongest of the species that survive, not the most intelligent, but the ones that are responsive to change. Let us match our actions forward, and let us redefine our values and relevance to the society today. If we can do that, we are going to have a long, greater walk to freedom, like what Nelson Mandela said. No easy walk to freedom. In summary, Dr. Solomon, I'm not accused of overstretching my 40 minutes to 1 hour. What I've told you in the last 14 slides is to make you know that as a consultant, you are to provide high-level clinical specialist inputs. As a consultant, you are expected to demonstrate independent and autonomous practice. You don't need to be consulting people. You don't need to move around. In fact, you know that most of the consultants, the physicians that have an established issue, they make errors. They make errors, but they stand by their errors. They look infallible. It's not true. You go make those mistakes for God's sake. As a toddler, you will fall. When you are taking your child too careful that the child should not sit because he may fall, that child will not sit down after 1 year. You are too careful that the child should not start toddling because he may get injured. That child will not walk for 5 years. Let the child sit, fall, hit head, scratch the forehead. Let the child walk the toe, fall, peel the knee. After 1 year, after 1 year, 6 months, after 2 years, it will get to a stage and the child will do a mockery to the mother. The mother cannot even run near him. The mother tells the mother will fall. That is what we should be able to start doing. Let us toddle, will fall. Let us crawl, will fall. Let us walk up, will fall. We will get to a stage, we will run and nobody will catch us. In summary, too, a consultant pharmacist should show competence in the chosen field of specialty. I've mentioned 2 examples how you can relate to your physicians and direct them, educate them, give them a guide. They'll be your friends. We should be able to develop teamwork, work together as a team. We should be able to offer specialist opinions to other health providers. We should be able to give a lead in our team. And we should provide mentorship to the younger ones. This is a very key and cardinal importance to me, mentorship, leadership. We should be able to develop modules for training. We should be able to develop modules also for education. We have to be teaching the younger ones, educate them. Education here falls across academic, practice, and life, so that they can have a positive thinking life. We should be able to provide drug information services to other health professionals. Nobody knows drugs more than you and I. Let us hold the bull by the horn and express our confidence to these people. Let us educate them. Most importantly, I have stressed this over and over. Our participation in research is very important. We should be able to do that. Our research outcome will guide our policies, and it will also help us in the development and promotion of new practices and innovations. Permit me to end my discussion this evening with this slide that you are seeing. These are people that have made history. These are people that you can, they can be you. Look at David and look at Goliath. If you are giving me a catapult, I will just use it to kill maybe a bird, or maybe scare a lizard. But David used the catapult and killed Goliath. To my right is Serena Williams. She had won a lot of laurels. World championship. She's a multi-billionaire by table tennis. When you give me the table tennis and the racket, the tennis ball and the racket, I can just smash it by the wall and return it. These 2 guys you have seen are heroes in their football domain. They have won several world footballers. But if you give me the football today, it's just like any round letter that I'll use and play with it, and nothing constant. But give it to these 2 people, they will get live out of it, and you'll be excited to stay and watch them. Of late, we also have our own brother, Anthony Joshua, who did wonders with his group. You have your own wonders too. The tablets, the drugs, the serums, the information on drugs. You can also redefine yourself as an individual, redefine pharmacy as a profession. The glory of God, you will enter the book of records too, as there was a pharmacist that worked in this hospital. It's a consultant in this and redefine pharmacy profession as the world. I always say, the world, you might be 1%, but the 1% you might be your action or inaction as a pharmacist in the hospital can change somebody's entire life to become something. And if you do that, you will give the world to that person. Thank you very much for your time. Thank you for your patience. I will now leave it open for comments and questions. I hope the network was friendly for us.
Thank you so much, Professor Wanang, for this soul lifting lecture today. Even from the far and near, and from the rest of pharmacists that are on this program this night, because most of them are so much interested in this particular topic because it has a pervasive interest in the mindset of all of us. But funny enough, the network refuses to be a friend in this today that we are so much interested in this beautiful lecture. But as like I keep on responding to them, it is not a fault from the moderator. I am here, yours sincerely, Dr. Solomon Kelechi Wafer. It is not equally a problem from the side of the technical crew, Dr. Ibrahim Bello, but actually it's from that of Brian. You cannot stop Prof because actually I texted him severally to know whether he can remove and actually re-log in. But the lecture is already going. It is not his fault. It is a network. But more especially, we have to be very grateful to this lecture today. We thank Professor Wanam because it's not easy for him in his tight schedule to actually live all these things. That shows that he has so much passion and love for us as pharmacists. But be that as it may, I will actually have to apologize to people that were unable to be highly participant in the coherence of this lecture this night. It is one of all those things. We can see it as an accident because in life, you can engage in one place or the other, and what your expectation might not be whatever you did. But the point is that Professor Wanang is always very much available for you to call him privately because he's a friend to me, and I know he's a very good person. He can attend to you, even not even minding his positions in one place or the other. I have to appreciate our brothers from across the world, more especially from the ones from the West African sub-region and from other parts of Africans like Liberia, Ghana, Sierra Leone, and the Gambia. I cannot actually express my happiness this night, more especially to this particular topic that is highly needed by all of us. But all of us will have to understand before we go into questions, contribution, appraiser is that they said, who is a consultant? As a consultant, you must be a bibliophile. You must be a book lover. If you love that book, you'll be able to be a researcher. You'll be a clinical governor. You'll be a clinical service provider, an expert. You'll be able to collaborate. As I keep on saying that whether you're a lab scientist in the hospital, whether you are a nurse, whether you are a physician, whether you're a dental therapist, a dental technologist, a physiotherapist, occupational therapist, you cannot work without a pharmacist. The product they use, our products. That means we are relevant in every area in the hospital. And for us to know, I keep on telling the people, even some people I did preceptorship or people that I teach in one way or the other, I let them know that before medicine, before other professions, pharmacy was. The apothecary, whom we reverence very much, is a pharmacist because everything started from the compounding and thereabout. But be that as it may, I am actually going to leave this floor for people to appraise, for people to ask questions, for people to contribute before there are other things will fall in. Thank you so much, Professor Wanang. Thank you so much for the fellows of Pharmaceutical Society of Nigeria that are participants in this program. Thank you so much for the fellows of West African Postgraduate College of Pharmacists. And thank you so much for the fellows of National Academy of Pharmacy. All of us together, we can win this war. And I believe with all of us, we will make it work. Thank you. And the floor is open for questions, comments, contributions, and appraisals.
Dr. Solomon, I have a question.
Okay, go ahead, sir.
Okay. And thank you very much, Prof, for that well-delivered lectures on the expectation of a consultant clinical pharmacist. It has to be noted that a specialist is an individual who has demonstrated a designated level of competence beyond that of the entrance level licensee. And that means a specialist, for instance, takes a very sophisticated body of knowledge and combines it with extensive clinical experience in order to formulate complex decisions that will help to resolve a drug therapy problem. So I want to ask, how well, as the Secretary General of WAPCP, how well is the college be repositioned to deliver on this mandate. So that when a consultant clinical pharmacist speaks, you should be able to separate him from a generalist pharmacist. So how far has the college gone to develop such specialization in clinical pharmacy? Because the college, as it is presently constituted, actually award general fellowship in clinical pharmacy. And we should go beyond that if you want to actually deliver on that mandate of say, okay, a clinical pharmacist to do this, you should be able to provide higher level of pharmaceutical care, you should be able to conduct research, you should be able to provide mentorship. Or then, has the college been actually repositioned to deliver on this mandate for their students? That is my question for the Secretary General.
Okay. Am I to answer the one or accumulate all your questions?
You can go ahead, sir. You can take it one after the other. You can answer him, sir.
Okay, I'm really happy that you are interested in what we do at the college. But I'm afraid you are not very, you're most likely a little far from the college. When I became Secretary General, we were operating the generalist pharmacies, generalist certification in clinical pharmacy, in public health, etc. etc. Me talking to you, I'm a consultant in clinical pharmacy and a product of the generalist clinical pharmacy. The first thing that we do is to crack the individual faculties into subspecialties, into specialties and subspecialties. What we do as a college now, with the introduction of the primary, those of you that are graduates of the college or students of the college know that the year I came in as SG was the year that we started primary. But I'm not taking a credit because it's not me that initiated. As a matter of fact, Professor Erun and Professor Okara started featuring the idea of having primary. But when I came on board, we held it hook, line, and sinker. The energy, we diverted it into that, and we initiated primary. That gave us a leeway. We dropped down plenty courses that were done in part 1 to primary. So now primary, they run 12 courses. Then our part 1, the first contact is the general contact, whereby all the students will participate in all the courses. Then in their second update, is now faculty-based. Those in clinical pharmacy will do clinical pharmacy courses. That means those in part 1 were doing what my generation did in part 2. When they are entering part 1, contact 3s and contacts 3 and 4, still in part 1, they will now go into specialization. Then they will start doing their residency in part 1. 6 months residency in part 1, because we know the residency is the only way that can give them the exposure that we need. Then when they come to part 2, they will go into subspecialty. In clinical pharmacy, for instance, there are 7 subspecialties that we have identified: cardiovascular, endocrine, and renal as 1. Oncology and hematology as 1. Critical care as 1. Mental illness as 1. Like that, we have 7 areas of subspecialty. Public health has 4. Not one of them has 3. Like that. Out of the 5 faculties, each of them subspecialized. So let me come down to clinical pharmacy. You subspecialize in hematology and oncology all through your second year, so that you know it in-depthly. You participate in an entire update discussing only hematology or discussing cardiovascular. Then your residency will also be from the same area of specialization. Your dissertation should equally be from the same area of specialization. If we do that, you can comfortably say this is a specialist in this area and a subspecialist in that area. We may not get it to 100%, but I can assure you we are 70% at the WFPCP, repositioning our curriculum to fit into particular areas of specialization. Hello? Hello?
Yes, we can hear you. We can hear you, sir.
Okay.
I hope Solomon can see the people raising hands up. Dr. Solomon or Dr. Bello?
So I want Prof to stop sharing the slides, sir. Can you stop sharing your slides, sir?
Oh, okay. Okay, I should stop sharing.
Yes, sir. Yes, sir.
Oh, sorry. Okay, I'm coming.
Okay, sir.
Sorry, let me stop sharing. I have to revert to my handset because the laptop was not giving me clarity.
Okay, sir. Okay, it's okay, sir. Okay, better now. Better now. Okay. So I would like to call on Pharmacist Bola Oladokun for his own comments. Pharmacist Bola Oladokun, can you go ahead or mute yourself and ask a question, please? Pharmacist Bola Oladokun, are you still there? Okay. Dr. Joseph Madu, our chairman, on to you, please.
All right. Thank you very much, Dr. Bello, Dr. Solomon. I hope everyone can hear me clearly.
Yes, we can hear you.
Yes. Though Prof's lecture was really cracking, and I think there was a time I even had to log out and log in again. But I want to use this opportunity to appreciate Prof. He has always been helpful and been there for us clinical pharmacists in Nigeria. I know he's a producer of clinical pharmacists at WAPCP. And we know that clinical pharmacists are also produced in the universities too. So we thank Prof. He has always been there with us. But then I would like to make a comment or ask Prof a question. Sorry, I hope you can still hear me.
Please go ahead.
Yes. Somebody was talking to me at a time, and he said he attended an interview, and he was saying that his title, he presented one of his titles as FPC farm. And then the employers were asking him what is the meaning of that. And he was telling them it means Fellow of West African Postgraduate College of Pharmacists. They said, but you wrote FPC farm. There is no West Africa anywhere there. The PC farm does not, Postgraduate College of Pharmacists does not denote anything. And the guy actually is still with us in Sipan. He was telling me that like West African College of Nursing, West African College of Physicians, they all write FWACN or FWACP. Even PSN, we have PSN, then we have FPSN, FNIM, National Institute of Management. And all those things stand for those bodies. But for West African Postgraduate College of Pharmacists, it is said FPC farm, which means it's not specific. So he was telling me that the people were really against it. And since then, he has been writing FWAPCP. I know Prof has explained this to us at one time. That is the decision of the college to use FPC farm. But I don't know or what Prof will say when we are relating it to other schools or institutions that the name is there or the abbreviation of the name like PSN, WACP, WACN, and then the fellow F is attached. So I don't know what Prof will want to say about that. Then secondly, another issue is that there are persons that also say they may want to know. They probably have started West African College in part 1 Probably they passed and they dropped out about, let me say, 10 years ago, especially now that the consultancy pharmacy cadre has been approved, whether they still have opportunity if they can still come back. So I would like Prof to react to those two areas. Thanks a lot, Prof.
Okay, thank you very much. In fact, I had to switch on to my own handset so that I can understand clearly too. I sympathize with a lot of you for the non-clarity of my presentation. I think the network is being unfair to all of us. Now, let me answer from the last. Those of you that dropped out of the college years ago and want to reactivate, we gave you a window period 1 year ago. A lot of persons came for that. We extended it to this year. Several persons equally came for that. As a matter of fact, they closed the amnesty. Amnesty was closed last year, 2019. But we pleaded with them at the F&G, at the JFB meeting. I appealed to JFB they should extend it to this year, which they did. So amnesty was given last year and this year. I wouldn't know whether amnesty will still be given next year. Coincidentally, my tenure as SG will finish in March, April next year. We are going to have a new SG. My prayer is the new SG or the new ESCO will accept that appeal. But it may not be a problem because we are eager to also be part of development. I know it will be discussed at the place and we shall recommend that they can always reactivate with a penalty fee that each year that you missed, there are certain figures that will pay, which I don't know, but administration will communicate same. Let's wait and see at the council meeting if the decision will be that the amnesty can continue for 1 more year. But the regulation says 2 years away from school, it is believed that you have self-withdrawn yourself. That is it. Then on your issue of the nomenclature, that is purely on the purview of the council. If the council strongly feels that they should change the name to FWP, it can be done. But I know that in those days, it used to be that FWP before they converted to FPC farm. But the truth is, anybody that says he doesn't know the FPC farm in an interview is just being mischievous, because a profession can decide to name their certificate or degree based on what they feel or the philosophy behind it. For instance, my University of Jos does not give MBBS, it gives BMBCH. That does not mean it is not the same thing with MBBS. Some universities give MBBS. Some universities give bachelor's degree in medicine, bachelor's degree in surgery, but they don't call it MBBS, they call it BMBCH. And that's what my university gives. So let us not be, but there are some things that the interviewers could just be deliberately being mischievous. But FPC farm is a popular nomenclature in the health circle. No pharmacist does not know that. No health worker under WAHO does not know that.
All right, Prof. Thanks a lot.
Thank you.
Thank you so much, Prof. Somebody asked a question. What is the duration of consultant training now in West African at West African level? I know that is a simple question. You've already said this is 5 years. So
Yes.
we can move ahead to Bushra Bello is raising his hand, or is I don't know whether he can answer. Let him. Bello, are you there, please? Can you unmute yourself and ask Prof the question so that he can go ahead?
All right. Good evening, Professor Wanang and all other members of CIPAN and senior colleagues present. I want to thank the organizers. It's a very interesting session, and particularly Professor Wanang, in his usual manner, he has dazed us and dealt with us intellectually tonight. I have a few concerns, sir. And first, let me mention that well, I call it a stinker because it's not. I don't just want to be outraged by it. The letter posted from enemy, and I want to suggest that we put all necessary arsenals to respond and to deal with that issue appropriately. It's really an assault to insinuate that government should build companies, pharmaceutical companies, where we should go and become a consultant. It's really, really bad and unbecoming of them. So I would love Prof and the college to also play a role in dealing with that issue. Now, concerning the discourse of tonight, I want Prof to comment. I want to make a comment, and I want to hear from him. I think the problem is quite multifaceted, and we need to understand all the problems and be able to address them appropriately. The first level of this problem, I think, is from school. And well, a lot has been done. Thank God we like Prof said, we have reached the stage of PharmD now as a basic clinical degree requirement. But I'm still not very comfortable with the level of its implementation. And I'm aware that at least Unibem is championing that course of making all the lecturers in clinical pharmacy to have the qualifications for that. But I see a situation like the condition in which I trained, and I don't know how much it has improved now, that students are taught on how to deal with patients in class, and they don't find their teachers by the bedside. It may happen otherwise. Maybe it may happen as expected in some universities, but in many other universities, you don't see the teachers at the bedside with the students. So that mentorship that Prof talked about, ab initio, is not there. And this is not what obtains in medical practice. You will see that whatever becomes of a doctor today was initiated at training. And I think that is a major problem. And this may require a lot of overhauling, kind of.
I agree with you absolutely.
Yes, sir. So this is one angle.
It is
second angle, sir.
Completely.
Yes, sir. So the second angle is the hospital itself. I want to know from Prof, since he is in a university and that university has a teaching hospital, what is being done to integrate the way the medics do it, such that the professors in the university are also teachers in the hospital? Such that, the stuff is present both in the class and then at the bedside. Because this is one of the motivations for even the students that you take to the ward. If you tell us all these things in class, when you get to the bedside and you don't find your match, then there is no way you see, if you take the average, not every student will have the confidence to stand up to what he is going to see in the field of practice. So we also need to look at situations where we are going to integrate that in practice. So that one of the things we find is that the hospital pharmacists sometimes even quarrels with the academic pharmacists. They say, oh, they don't understand. They are in the class. Why don't we, merge this experience so that, just like what we know in the developed world, the industry feeds the academia and the academia feeds the industry. Then lastly, at the level of specialty, I thank God Prof has said a little bit about it, and he said it will always continue to improve, because the bone of contention of that NMA letter, is that, okay, what are the what do we call it? What are the roles of this consultant pharmacist? And if we just say, oh, it's clinical pharmacy, optimizing patient care, yes, but that's still generalist. Is it we need to narrow it down so that the standard of practice everywhere. So I want.
Thank you so much, Fambello. Thank you so much. You are taking so much time, please, because we don't have much time, and on our side,
I'm done.
there are some other people that are still raising their hands, and some other people that still have to talk. Please, let's make it 2 minutes so that Prof can easily go and retire and sleep. So, Prof, please, can you respond to that so that we can call other people to actually contribute to?
The 3 questions are matched. I can match them and answer as one. You see, the truth, you cannot have a perfect document. Documents, even the curriculum of the most perfect system will evolve and change. That's why you do curriculum review every 3 years. I am with you, I agree with you, we need to change right from the undergraduate. We teach in silos, no problem. We have identified all these issues. But remember in my talk, I quoted Nkwame Nkrumah by saying enough of lamentations. Let us organize and do it right. Part of the organization is what we are discussing now. Let's go ahead. Next question.
Thank you so much. Dr. John Juma, please, you are the next. Please, make it 2 minutes, please, or a minute. Dr. John Juma, are you online?
Okay, yes. Good evening.
Good
evening, Solomon. Good evening, everyone.
Good evening, sir.
Thank Prof for that wonderful presentation. Actually, you have hammered, you have nailed you put the nail on the right place. The truth of the matter is that you cannot give what you don't have. Just there is defect in our pharmacy curriculum right from the schools in the undergraduate level. Whether we like it or not, that is just the truth. But some of us have been able to develop our capacities even outside the school. Even when I was in the college, it was still the same thing. Just theory. I'm surprised that Prof, because the last result that was turned out, I didn't see any classification. It's still the generalist results that was turned out from the West African Postgraduate College of Pharmacists. If we have such specialization, as you said, sir, then it should have featured prominently in the result that was just released of the college. And
can I make a correction?
Mentorship. The problem we are having.
Hello, Dr. Danjuma. Like, Prof, want to react to your listing. At least you've made the point. The generalists and specialists. Let him just quickly react to that, please. Yeah.
Okay.
Like I told you, those that graduated last year, they didn't do primary. They didn't start with the primary, please. It is those that are in part 2, contact 1, that did primary with my batch that we started this curriculum, I'm telling you. So the last result, of course, has to be with the curriculum that they came in.
It's okay. But sir, a lot still needs to be done. If there are...
It's not a perfect document.
Some of us around here, because we are trying to set up top specialization in the hospital here, so that we have a structure on ground that when residents come from the college, they should just fit into the system. That is what we are trying to do over here. So thank you for this wonderful presentation tonight, sir. Thank you.
Thank you, Dr. Danjuma. Please, Dr. Jiro, are you around? Can you put in your question? 1 minute, please. Dr. Jiro. If Dr. Jiro is not around, Pharmacist.
Yes, I'm very much here.
Okay, please go ahead.
Thank you very much for the opportunity, and thank you very much, Professor Wanang, for a wonderful delivery. I've always enjoyed your discussions anytime you speak. Like Prof rightly mentioned, we have high expectations. Like he also mentioned, Rome was not built in a day. I believe the college is on course. However, there are little amendments that can be done. A lot have been said about the undergraduate level. Even at the college level, some of these courses should be taken by, I believe some of these courses should be taken by practicing pharmacists. Using university lecturers who are not practicing to discuss cases, to discuss lab results, like in my case, during my part 2, I think it's a little defective, and that is something that can be corrected as soon as possible, especially with this new curriculum that we've been talked about. So the college should look at various institutions and use practicing clinical pharmacists to take cases rather than the university lecturers, because currently there is a disconnect between the university and the hospital practice. And for those of us who are in the hospital, who are preceptors, we need to also up our game and actually show these students that come to us the practical aspect of training. And like I keep appealing to our colleagues in the universities, there are practicing hospital pharmacists, both in the clinical pharmacies, both in the community and in the hospital, who are willing and able and capable to lecture in these universities at adjunct capacity. Those in the academia should also make this window possible, because it is easier for the pharmacists who are already in the hospital to easily go in with these students. So there should be a lot of interaction between the universities and the hospitals. Thank you.
Thank you, Dr. Jiro. Prof, do you have anything to say about that one? Is a straightforward something. It says it's straightforward.
Let's go ahead. Go ahead.
Pharmacist Ibrahim Yahaya, are you there? Pharmacist Ibrahim Yahaya, are you there? Are you there, sir? If you're not there, can Pharmacist Namma unmute himself and speak?
Hello. Yeah. Good evening, everybody.
Good evening, sir.
I want to appreciate the CPAN for organizing this wonderful presentation, and I also want to thank my mentor, who is the guest lecturer and SG of the college. I want to say one or two things pertaining maybe disconnect between university and teaching hospital. I think it should be specific to some universities and teaching hospitals. Like I remember there was a time that preceptor training was organized in University of Jos, and most of the pharmacists in Jude, Plateau Specialist Hospital, and other clinical centers were trained as preceptors. And they have been doing extremely well. Some of us were lucky to have passed under them at the postgraduate doing our MSc in clinical pharmacy. So I believe some other institutions should also follow same to be trained as preceptors. Yes, I still agree that our lecturers in the university need to have change of orientation. They need to practice, not just to be isolated in the universities. Then lastly, the issue of specialization. The curriculum is supposed to provide us with just a guide, and it's left for you and I to choose area of our specialization, area of our strength to develop ourselves. We have seen some people that had ordinary BPharm, and some developed themselves in different capacities. And I don't think that there is no any curriculum that is perfect. Curriculum is supposed to give us a guide, and sometimes most of us don't even read the curriculum or the prospectus. For instance, during our stay in the college, I challenged some of our colleagues. When you read the prospectus, there are some guidelines that are in the prospectus. For instance, visitations. The college will not organize visitation for you, but the guideline is stated in the prospectus. You are supposed to visit a site for hands-on experience. So most of us don't actually follow the prospectus. So, and if we can follow the prospectus, there are things that you are supposed to learn on yourself, on your own, because this is an adult education. For us to specialize, we need to do extra work. We need to find some specialized courses, postgraduate courses or certificate courses that we can specialize. I always give example, University of Washington. They are doing so many courses that, especially those of us that have public health from the college, can specialize. Even those in clinical pharmacy, currently now they are going to start like mental health, which is public clinical pharmacy specialist. So I believe we don't have to rely solely on the college or the universities to train us. We also have to do our own part.
Pharmacist
I want to really appreciate everybody.
Time up. Thank you so much. Thank you for that. Please, Dr. Asphocius Peter, are you around, please? Can you quickly put in your own contribution or questions or appraiser? Please, the time is not on our side. Dr. Alphonsus Peter, if he's not very close, can Dr. Felicia Williams please come up, ma? Unmute yourself and speak, please.
Good evening, everybody. Prof, good evening, sir.
Good evening, ma.
We really enjoyed the down-to-earth talk. Sometimes or always, it is good to tell the truth. I wish it is possible this presentation is made at a bigger forum. When we tell ourselves the truth, it could be better, it may be the surgical operation we need for us to move forward. The in-house fighting is disintegrating us so much that we don't even have strength to fight the outside.
Exactly.
It's high time to put our house in order so that we can strengthen ourselves for the outside world. Prof, you have done so well. Thank you so much.
Thank you so much. I appreciate you.
Thank you, Dr. Felicia Williams. Please, Dr. Alphonsus Peter, is he around? Pharmacist Ugwany, is he very close?
Good evening.
Dr. Peters, are you around?
Yeah, good evening.
Good evening, sir. Please speak on.
Good evening, Prof. Good evening, Prof.
Yeah, good evening.
I appreciate you, sir, for always being by us and for all the multiple times I've had to call you to join presentations and so that you can advise us appropriately. I must say it's a wonderful. You know, my own contribution, specifically, like when I have said that we can only start from the instance that was quoted that who was the first gynecologist. The first gynecologist was somebody that was not a gynecologist before he was made a gynecologist. So it goes to tell you that that hands-on skill that will make the difference is something we should do whatever we can do to acquire. And like the 2 or 3 last speakers, we need to go beyond what we are doing now. And we need to locate champions among them. By champions, I am not talking about those that have all the degrees. By champions, I'm talking about those that are already doing what we are to be in terms of experience and expertise. There are people like that, especially in community and in some hospitals. We know them. The last speaker said that surgery to some professional. And I sort of pharmacy attempt to answer those gray areas seem to be taking on us. They are asking us to go to the industry. They know most of them are to the academia. That academia meeting somewhere. Just let's find their way. I'm not taking that integration of locating people that are ready fill those gaps that we have. Do the about always there are a lot of people that are do already very short time the best. I have a lot of foreign pharmacists from other African countries that have been communicating with me privately. Foreigners are depending on And most of the time, the state and what you say would make you to actually know whether or not what you are.
Dr. Peter, remember our closing time is just 4 minutes. 4 minutes on the way to close.
Thank you. That's my question.
Pharmacist Max. Pharmacist Max, are you there? And Pharmacist Abdullahi. That should be the last contribution. 1 minute so that we can close, please. Pharmacist Max, are you there? Pharmacist Abdullahi, are you there? Okay. If you're not there, please. Okay.
Dr. Solomon.
Okay, my chair, sir.
Yes. Please, I still want to remind Prof and everyone present this night that it is true that NMA is fighting us, and it's because we have been recognized as consultants in the clinic settings or in the hospitals. But then there is also another problem that is even really bothering me. The FPC farm we have been producing, we are not using them. I don't think the PCN has even recognized that. I don't see people being employed with FPC farm as lecturers. I don't see people maybe in the other sectors looking for pharmacists and seeking FPC farm. I also know that to even be a consultant, as we are discussing right now, is not necessarily because you have a FPC farm, because FPC farm is a qualification, but then you will be appointed as a consultant by a health institution. So I will like us, both as the college is fighting, and thank God today CIPAN is also an interest group of PSN. That means we will be having a voice at PSN council meetings. We should also be talking about using that qualification FPC farm, not only to go and NMA is feeling that we are threatening them. By the time they see people with FPC farm being employed as lecturers and in other places, I don't think they will not be getting disturbed when they see us coming to hospitals as well. Thank you very much.
Thank you so much, our national chair, our able chair. Please, I don't know whether the chairperson of CIPAN National Education Committee is around to give closing remarks. Why Dr. Ejiro should lead us in closing prayer. I don't know whether he's around. Is he around?
Oh, no, he's not.
Dr. Tim, is he around? Okay, he's not around.
No.
In the absence of that, let me do it on behalf, because we are two people in one body. Prof, thank you so much. I am using this medium to thank everybody that is here this night. And more especially, I agree with a speaker that said from the school had a problem. I developed a model where I call initiation model, development model, maturation model, and expertise model. In our initiation model, there is a default. The lecturers in the university are not always very close to the students. Maybe they believe when they threaten them and harass them, that's when they'll be able to sit down and learn. But I doubt, because I believe in the universities, the College of Medicine and others, they start giving them that idea that are the kings in the hospital. We equally be giving our own students the idea that before medicine, pharmacy was, that apothecary is equally a pharmacist, that even if they like in the hospital, they cannot treat with water. Even if they try to treat with water, water is a combination of hydrogen and oxygen. And those are the components of even a drug. So we let them know that we are the life wire, we are the engine room, we are the drivers, we are the blood of hospital. So we create the confidence in them. And in development, when they do their internship quality, it follows. When they mature and become independent, and when they become an expert, those things will help. And thereabout, I thank Professor Wanang this evening and thank everybody that participated. At this juncture, I am calling on Dr. Ejiro to lead us in closing prayer. Dr. Ejiro, are you there?
It's not on the call. It's not on the call.
Okay, if Dr. Ejiro is not there, I don't know whether Mommy can do it for us, please. Dr. Felicia Williams, please, Mommy. I'm sorry to pull you along, but please help us in closing prayer.
Professor Williams.
Sorry?
You also lead the closing prayer.
Sorry, please. Can somebody else pray, please? Please.
Okay, Dr. Danjuma, are you there? It is unfair if I do the closing remark and do the closing prayer.
Okay, let us pray. Let us pray.
Amen.
Amen.
Continue.
Continue.
Hello?
Hello, we can hear you. Continue, please continue.
Okay. We thank you, our God, for leading us through a successful deliberation. We pray that you will help us to implement what we have learned in Jesus' name. Amen.
Amen. Thank you.
Amen.
Good night, Prof. Good night,
Thank you
everybody.
so much, Prof. We appreciate you, sir.
We appreciate you. Good night, our national chairman. Good night, everybody.
Mom Solo, good night.
Good night. Good
I
night.
love
you.
Oh, we appreciate you. Good night, everyone.
Stay safe and healthy.
Much love. Good night.
And happy New Year.
Bye.